Hello, and thank you so much for viewing my poster on unusual esophageal findings in a patient with lupus. My name is Abu Fahad Abbasi. So, dysphagia, chest pain, and reflux are well known esophageal manifestations in patients with SLE. The incidence of heartburn and chest pain are common, and they present up to 50% of patients. However, dysphagia only presents in 1.5% to 13% of these patients. We review a case of a patient with lupus who presented with all three esophageal manifestations at the same time, which has not been well documented in literature. Of note, reduced lower esophageal sphincter tone is more commonly described in patients with connective tissue disorders. Aperistalsis in the setting of chest pain, reflux, and dysphagia in lupus has rarely been reported. We have a 40-year-old patient who is a veteran with significant past medical history of SLE that presents with atypical chest pain, dysphagia associated with GERD on multiple occasions. She presents afebrile, she is hemodynamically stable and mildly tachycardic. She's saturating well on room air and usually continuously being worked up for cardiology, etiology, and which is consistently negative. She usually has an unremarkable chest X-ray and no leukocytosis. Of note, there's usually an incidental finding of patulous and fluid-filled esophagus on her CT chest, which notes back several years. While GERD was now high on the differential, the patient failed to respond to proton pump inhibitors, and she presented to the emergency department with chest pain multiple times thereafter, being worked up multiple times for cardiology etiology. Finally, she's seen at the GI clinic, and she's worked up now with esophageal manometry, which we have here in Figure 1, where the patient has which is remarkable for complete absence of esophageal body and peristalsis with normal LES resting and slightly reduced relaxation. This was followed by a pH impedance test where the patient was off of her PPI, and this confirmed in Figure 2 that she had 6 out of 7 chest pains were related to her acid reflux events. SLE-induced esophageal dysmotility became a more likely explanation for her symptoms, and patient is now currently being treated with high-dose PPI twice daily, Carafate, and repeat bougie dilation as needed as the patient's dysphagia if the dysphagia worsens. So our patient presented with a unique combination of all three esophageal manifestations of chest pain, reflux that is partially responsive to PPI, and dysphagia. An esophageal manometry and an esophagram, she demonstrated aperistalsis but did not meet criteria for achalasia by the Chicago classification. While this is well known that long-standing reflux can lead to esophageal dysmotility, we believe that our patient sustained neurological changes due to underlying lupus over the years, resulting in slowly progressive dysmotility and eventual aperistalsis. See, unlike non-lupus chronic reflux patients where reflux leads to eventual esophageal dysmotility, we believe that our lupus patient's reflux was a result of poor esophageal clearance, resulting in chronic dysmotility and eventual aperistalsis. Cardiac workup should always be completed first, as lupus can involve the myocardium as well. However, repeated emergency room visits, primary care visits can be avoided if this patient's complex of chest pain, reflux that is partially responsive to anti-secretory therapy, and dysphagia can be recognized earlier in patients with lupus. Cases like this often require higher doses of long-term anti-secretory medications and acid-neutralizing medications along with co-management of visceral hyperalgesia. See, these are my references here, and I'd like to go ahead and say a special thank you to everyone that's viewing my poster and my mentors and colleagues in the internal medicine and GI department at Loyola University Medical Center and Hines VA Hospital. Thank you so much for your continual support.